This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
It's my very great pleasure to welcome and introduce Professor Andrew Wolfe as a paediatric plenary speaker for our conference. Professor Wolfe is Professor of Paediatric Anaesthesia and Intensive Care at University Hospitals in Bristol. He's also President of the Association of Paediatric Anaesthetists of UK and Ireland. Professor Wolfe trained in the UK and Australia with a particular interest in paediatric cardiac anaesthesia and intensive care. In 1995, he returned to Bristol to develop a new paediatric cardiac program following the high-profile review of the Bristol cardiac services. Professor Wolfe divides his time between Bristol and helping to develop a paediatric cardiac program in Chicago. He'll be sharing his knowledge during this conference on his research interests, which pertain to paediatric hypertension, sedation, modification of stress and inflammation to surgery, and fast-tracking cardiac surgery. Professor Wolfe may not have an opportunity to practice his bagpipes, although I'm told he's expert at these, and he's also an expert knitter, so if you see him knitting, then go up and give him some tips. But we do hope that he can indulge his love for cycling while he's in New Zealand, and I gather that he's been given a good itinerary for the week after the conference, so he was keen to accept our offer of coming. So meanwhile, it's a great pleasure that in keeping with our theme of under pressure, I invite Professor Wolfe to share his experiences of going beyond Bristol.
Thank you very much, Fiona. That was great. Thank you. So my great thanks to the organising committee for inviting me to somewhere I've never been before that looks absolutely fantastic. So I've spent time in Australia, but New Zealand looks equally fantastic. What can you say? All right, so this talk is going to be in two halves. I want to tell a story to start off with, which is the story of Bristol and how things didn't go as well as it should have done. And then the second half of the talk is to look more analytically about how you develop a cardiac unit and what the checks and balances are through that. So this is my first slide, and this shows a very beautiful bridge. This is a beautiful structure made by Isambard Kingdom Brunel, and it is in Bristol, and it's the suspension bridge. And this is a bridge that changed history. It was one of the first suspension bridges, and it's very elegant, and everybody copied it. This is not such an elegant building. This is the Bristol Royal Infirmary, and this is also a famous building because this is the place that the Bristol Heart scandal came from, and there were pictures of this all over the world for many years. Pediatric cardiac surgery has long origins. It started obviously with adults, 1950s, early 1950s, where the great pioneers who really were very brave people. They undertook very difficult things to do. And this is an adult about to undergo cardiac surgery. They cool them down. The bypass pumps took all day to pick up. The outcomes were atrocious to start off with. You were lucky if you survived. And the consent form, this is a consent form for one of the very early operations on a child. This is John Gibbons, who was doing the operation. And it simply says, I give my permission to the doctors of Jefferson Hospital to perform any operation or treatment they deem necessary on my daughter. So they took bravery on everybody's part, bravery on the part of the parents and the hospital doctors and everybody else involved. And it was a bit of a wing and a prayer. We've come a long way since there. So the first real look at outcomes was done by Janos Stark, who was very interested. He was interested in outcomes. He was a cardiac surgeon of his generation in Great Ormond Street in London. And he was looking at data. He managed to get data, which is very hard to get even, 1988, on outcomes. And this is for children under the age of 1 having cardiac surgery between 1998 and 1991. And the things I want to point out to you is if we come over here, I've got 2 pointers, so I'll just do it with 1 pointer. So, I've swapped the slide already. Oh, let's go backwards. Let's try again. Okay, let's try this. So this is the worst centres were producing a mortality that was over 40%. I mean, that's staggering now. Under 1 year old, mortality of 40%. But even the really good centres had quite a significant mortality. Things improved slowly, but even in 1991, there was a massive difference between the best centres and the worst centres. And there wasn't any real management to do anything about that. That was just what was happening. And I'm going to now go all the way forward to when the Bristol Heart Inquiry went on, when they actually looked at the data. And this is now taking this on from 1991 to 1995. So that's the next epoch. And this is a slide I'm going to show different types of as we go along. And I think they're important to look at this. These are funnel plots. And it's this guy, David Spiegelhalder, he is the professor of risk, if there is such a thing, in Cambridge University. He does medical risk. And he has done the stats on this and made it really his own. These are the 12 centres that undergo paediatric cardiac surgery, that undertake paediatric cardiac surgery. This is the number of cases they undertake, and you find an identity line for each of these. And this is the collected averaged mortality line here. So this is mortality, this is volume of cases. This is the second standard deviation from this mean. This is the third standard deviation from this mean. And you can see this little chap is sitting outside. Now, nobody knew those figures back in 89, 90. But when you look at back retrospectively, you can see that a couple of things. One you can see is that the lower volume centres tend to have the worst results. And secondly, there's this little chap here that is a major outlier. And, you know, if anybody knew that, then that should have been pulled up straight away, but it wasn't. And it wasn't really pulled up until this chap came on the scene. Now, Steve Bolson has been a colleague and a friend of mine over the years. He came from the Brompton Hospital, which was a really great hospital for paediatric cardiac surgery with very good results in London. He came as a new consultant, a young consultant doctor, and he didn't like what he saw. He saw very bad mortality. So he did all the things that you should do. He went and saw his superiors. He went to see the surgeons. And he said, look, there's a problem here. But he was warned away, and he was threatened, and all the things that whistleblowers have to suffer. And eventually he got frustrated, and he started to, in a way, go the back door because he was so frustrated. And he came into contact with this guy. This is Phil Hammond. Phil Hammond is a GP, but he's also well known for writing the medical section of this satirical magazine, which is called Private Eye. And, you know, if you remember Men in Black, they used to talk in Men in Black about if you wanted to know what was going on in the world, you had to look at the National Enquirer. Well, the Private Eye, if you want to know what's going on in the world, you look at Private Eye because it has grains of truth in everything. It's a very good magazine. And he went through that, and then he went through the Daily Telegraph, he went to the Royal College, and eventually it took a long time to get anybody to really listen. And this is an example of how it takes a long time to turn a big ship. So he arrived in 88. Everybody knew in the UK that there was a problem in Bristol. Everybody knew that. But nobody was turning the ship. He came in and started making waves. They had one last disastrous switch operation, and they stopped then in 94. And they did it, realised they needed to have a new team, and the new team then arrived in 95. But it took then, and you know, so the whole time from start to finish is about 10 years. So it takes a long time to turn a ship. What they had was an inquiry, a national inquiry, and that inquiry has changed the face of medicine, certainly in the UK and probably for many parts of the world. This guy, Sir Ian Kennedy, is a lawyer, incredibly bright man, and doesn't take no for an answer. He finds out where the base of it is. What he pointed out in his report was that there was a lack of leadership. People would come onto ward rounds, and individuals would do that. So the surgeon would come in and do his, then he'd go away, he'd make changes, then the intensivist would come along, and then the surgeon would come back and change that, and then somebody else would come along. There was no context of it. People weren't all doing things together. The unit itself had not kept up to date. If you looked at that slide from Janos Stark, the 88 data, you could see that everybody was improving. And if you had fresh blood coming into a new unit, you would improve. So as new operations and new techniques came in, people would improve. Bristol was a smallish unit in an isolated place. It never changed. It just stayed as it was. And therefore, although they didn't get any worse, they didn't get any better. And so as the mortality came down, they became an outlier. So the unit really wasn't up to the task at every level. It was at every level. They were doing the operations in the adult hospital. So you had essentially adult nurses looking after small children. The contacts with all the pediatric and all the adjacencies weren't really there. And it just wasn't a very good composed unit. There was a closed culture and secrecy. The head surgeon happened to be the clinical director of the hospital. He was also the head of the whole ethical formula for the hospital. And so when a young physician said, I think we've got a problem, he got nowhere. There was no monitoring of the data, something that it would be unthinkable now. So people weren't looking at the data and saying, hey, look, there's a problem, or this is all going well. And there was no accountability. The bad cases were just, oh, well, that's a bad case, let's move on to the next one. So nobody actually said, hang on, stop, let's think about it. And this quote, I think, says it all, really. This was the guy who was the CEO of the hospital at the time. He was a doctor, he was a radiologist, and his quote was, although I'm a doctor myself, I cannot intervene in the clinical judgment of doctors directly involved. And that says it all. We're all responsible. We're all responsible for our outcomes. Everybody has got to have an equal voice to make this work. So the origins of the cardiac unit come really from Melbourne in the sort of era of about 89 to 95. I was already a consultant at that stage. I'd qualified, I'd done paediatric intensive care, I'd done paediatric anaesthesia. I walked into the unit in Melbourne, and after about 5 days I thought I'd better start again, because the quality of the service that they were providing, in terms of everything, right the way across the board, the communication, the collaboration, the surgery, the intensive care management, it was all of a league order than I had seen in paediatric cardiac. And so it was like you start again. And it was down to lots and lots of people. Again, it's multifactorial. This guy, Roger Mee, who was a New Zealander originally, he was a good leader. He listened to people and he pushed things along. This is Sunji Sana, who was there. He was the number 2 at the time, and he became famous for the Sana operation. And it's Tom Carl there. And then this guy, who was the young surgeon who was working with them, and he then became my collaborator and friend in Bristol in 95 when we restarted the unit. And we started the unit from scratch, essentially with a few people who had this kind of experience. So when we arrived, it's clear that it was difficult. We still had some of the old surgeons who were working there, and it was clear there was a difference in quality between them. We moved everything into the children's hospital, and it was like starting again from scratch, because although we had some of the paediatric nursing team had worked in really good centres, they then had to form their own team, and we had to form a collaborative team. And we literally, effectively almost lived together with each other for the first 5 years. What we worked out was that if you could take it and make it work in one centre, it should work in another centre. And that's what we did. Cardiac surgery should be reproducible. And it is absolutely a team game. It isn't one person saying, this is how I want to do it. You've got to all collaborate and talk, and if somebody's not happy, they've got to say. And even in the best centre, and I saw that, near misses will occur. But the good centres are the ones that can convert a near miss into a result, because the team works together and you do whatever needs to be done quickly, and everyone's clear of their job. And the good units are the ones who can convert those near misses into good outcomes. And then finally, we had lots of issues with infrastructure, and we were very lucky. We were able to just say, well, if you don't do what we want, then we won't operate. And they said, well, you can't do that. And we just look at each other and say, yeah, we can. Yeah, we just won't operate until you tell us. And they had to give us what we wanted. That only lasts for a few years. After a while, they get wise to you. But it was good for a while. You can't even start without a good surgeon, and Ash was an exceptional surgeon. But you also need every single element to make it work. So the first 5 years was all about personnel change, changing the culture into a can-do culture of people who liked each other, liked to work together in a collaborative group. And the interesting thing is, if you set out a new unit, you find people who want to come and work with you. And that was absolutely fantastic. So we would ring up people and say, how do you like to come and work with us? And the people who you want to come and work with you are the people you want to be working with, and they were fabulous, absolutely fantastic. So we got some unbelievably good people, and they all came flocking in. So we ended up with this core of medical personnel, nursing personnel, physiotherapists. Everybody was all working to a common good, and it worked fantastically well. And I've always likened paediatric cardiac surgeon to high-level surgery to like a high-level competitive sport. I did competitive sport when I was younger. And it's all about every little element has to be just right to make it work. It's like the Formula One team. Every element has to work to win. And this is the concept they have in cycling, which is summation of marginal gains. Every little bit, those little bits that you think, oh, I won't mention it. Well, you should mention it, because every little bit can just improve it. And it should be, if you're either improving all the time or you're getting worse all the time. Nobody ever stays the same. But this is actually another concept, which is you're only as good as your worst performance. So you have a bad day, you have to analyse what went wrong, what did go wrong, what was the problem. And this is where we started. And this conference is, I see, it's all about pressure. Well, we had a bit of pressure. So when we first started, we did the first switch with the parents outside. These are all coffins, or, they're models of coffins. They were outside the door of the hospital. The press were there with their cameras outside the hospital. And we did the first switch. And we did the right thing. I think we actually got one of the best switch surgeons in the country to say, look, we're going to do our first switch. This is going to be absolutely unbelievable. And Bill Braun, who was another Melbourne person, came down from Birmingham and helped us out. And it all went very well from there. So that was great. But it was a lot of pressure. And the mortality dropped down really quickly from there. We joined actually in 95. In the middle of 95 we came, and it dropped pretty quickly. There was still some pretty wrecked hearts that we had to deal with, and that lasted for 2 or 3 years. We're doing redos on hearts that had hours and hours of cross-clamp time. They're never quite the same. So just briefly, the sort of PICU practice that we adopted, it's all about team game. You've got to have a leader. It doesn't matter who the leader is. It can be an intensivist, it can be a surgeon, it can be a cardiologist. It can be just one person who is the central hub. And then we're insistent that we have ward rounds twice a day. And there's always a third one as well, generally just the intensivist. But there was a ward round in the morning and ward round at 5 o'clock. And everybody must come to that. All the key people, not too many people, because that's the trouble. It kind of generated too many people in the end. But when you had a small unit, you've got all the key people there, you make the decisions, and it's a hub and spoke system. You can have as much conversation as you like by the side of the bed, but you don't move to the next patient until you've got a plan, and then that plan is activated by the person who is the leader of that. So that's absolutely key, is you then follow that. You've got to have some agreed protocols, but they're not going to be slavishly adhered to. Obviously, you've got to adapt according to what you've got, with discussion with everybody as you go along. And the thing that they didn't have before we started was planning and performance. You've got to plan, everybody's going to be there. So we have our meetings are there, the perfusionists are there, the senior nursing staff at the planning meeting, physicians, the cardiologists, the surgeons, and we discuss that. And then afterwards we look and see how it's gone and discuss it and debrief after it. And one of the things we also set up a long time before the WHO, because you're working in a new environment, we had checklists, we had briefing, we had formal written patient handover as we arrived on the intensive care unit, all those kind of things, which I think are absolutely fundamental to getting tightness. It comes down to summation and marginal gains again. It's all about these little tiny things that all add up to just be making you slightly a better unit than the next one. And minimising human error, which you can't completely eliminate. And this is what I wanted to talk about next. This is another Great Ormond Street, London cardiac surgeon who had a bit of a wobble with his switches. He had a few switches that didn't do well. And he was a wonderful man. He was a very thoughtful, and he would contemplate why it didn't go. And what came out of this was he got together with Jane Carthy, who is a psychologist, and they wanted to find out why sometimes operations go bad? And is there anything in terms of human factors that can be adjusted? And of course, human factor training now has become a big thing now. So they took the switch operation, which is a really good operation to take. It's kind of the same. There are variations, yes, and there are worse ones and better ones, but you're all going to roughly see about the same sort of thing. So first of all, these are the results, and each one's a surgeon here, along here. Each one are all the different surgeons in the UK. There's all the UK centres. And this is the number of cases. So no surprises for guessing that this is Birmingham. Almost certainly that's Bill Braun from Birmingham, who did most of the switches in Birmingham. And then you've got these little places that are just doing one or two. And then when you look at the outcomes, it all goes the other way around. So if you don't do so many cases, your outcomes are not so good. The blacks are the near misses, and the greys are the deaths. Please say that was Bristol. There was no near misses, no deaths, although we were a medium-sized unit at that time. So there is the first, and it's a very good paper to read because it goes into all the little things that in human factors that adjusted some of these mortalities. And the unit increased. So the first year we started, we just did 175 cases. We finally got a decent hospital to work in, nice purpose-built hospital, and in 2013, over 400 cases. So the sort of second part of this talk, I want to talk about how it develops from there, the beyond Bristol part of it. And as a result of Ian Kennedy's inquiry, this was formed. This is the National Institute for Cardiovascular Outcomes Research. And there is a database, as many places now have databases, but that was a relatively novel thing when it started off. With a collective analysis of the centres, every surgical outcome is monitored at 30 days and 1 year, and it's also freely available. So you can look at your outcomes of your centre online if you are contemplating coming into the hospital with your child for surgery. And I want to look at the statistics a little bit and just see how CCAD manage this data and how they help you. They're not a policeman. They're actually a help service. If you look, this is actually hip data. This is outcome, 30-day outcome hip surgery data in adults. If you look at just the basic outcomes, and this is the deaths at 30 days, then you'd say, well, if I'm having my hip surgery, I'm going to go to this hospital because it's got the lowest mortality. Well, I don't fancy going to this one because it's got a higher mortality. However, that data hasn't got in the numbers of patients that they're doing and the risk-adjusted nature of it. So you have to go to something like a funnel plot to actually look at that. So again, just to revise that, the funnel plot is, it's the volume of cases. So these are all centres. So this is a centre that's doing a high number of cases, and although its death from its hip surgery it's within 2 standard deviations from the mean. They're a high volume centre, and I suspect they were a group that are doing more difficult cases. Whereas most of them are all in the safe zone. There's a few that are outside the 2nd standard deviation, and they should be considering their practice and thinking, why is it edging outside the 2nd standard deviation? And this is a very powerful tool. The funnel plot is a very powerful tool at looking at your data. So let's now look forward to 2012 at paediatric cardiac data from the United States. And they're probably absorbing the same sort of things that Bristol had to do about 10 years before, or more actually, 20 years before. They got together and they wanted to get all the data from paediatric cardiac surgery in the United States. There are 120 centres doing paediatric cardiac surgery in the United States. That's a lot of centres for the population. It's a lot of centres, but it's a large population. They were able to get 93 centres to sign up for this study, looking at outcome. And of the centres, of those 93, only 73 were admissible data. I'm not sure why that data wasn't admitted. But it shows the same thing, and it shows where everybody can improve their practice. So these are risk-adjusted scores. So this is the lowest risk operations, the ASDs, the simple cases, where the overall mortality rate, which is down here, which is 0.6. And you can see high volume centres, very low mortality, small volume centres, higher mortality. And the problem with even the simple cases is you just need one death if you're a low volume centre, and it's going to skew your numbers. You're going to jump up this funnel plot in a big way. And as you go through to the more difficult cases, it becomes more and more obvious that there are centres that probably need to either change their practice or merge into other centres that have got better practice, more collaboration, and higher volume is good outcome. Generally, a higher volume will give you good outcome. And then you go to the highest risk centres. You've got centres here who are doing 1 or 2 cases with 100% mortality. And really there has to be, and I think it's happening, it is happening in the States, that there is a real move now to try and intensify that. I mean, that's already happened in the UK, it's already happened in the Antipodes, but it's still a long way to go. And this is where the real world is now. So this is truncus repair in the UK from the CCAD data. All the different hospitals have to admit their data. And what you do is you end up with quite a raggedy kind of picture, not like those last lot of pictures. They look raggedy because single data points or single deaths are going to change these standard deviation lines. And you can see truncus repair, it's quite a relatively high-risk procedure, good results all round. There's a couple of deaths, but these are from the high-volume units. And, you know, they may have been referred those cases because there's a particular problem. And you can use that data very effectively. So this is from the CCAD data, 3-year data. You can see that, well, this is Norwood surgery. The mortality is going downwards from Norwood surgery. It's getting down to really quite acceptable places. Whereas the BT shunt mortality has now crossed the stage 1 Norwood mortality. So it's less safe having a BT shunt than it is having a Norwood stage 1. And that's changed practice. And the reason why that's happened is because all the simple shunt patients are now having radical repairs. They're not having BT shunts, which is a horrible operation. And everybody hates it. And just to give you an example of that, this is the Bristol data from BT shunts. And we used to do, back in 2000, quite a lot of BT shunts for fellows. If they were very young fellows that were very blue, we'd put a shunt in and then come and do a second staged operation. Now we don't. What we do instead is they either have a radical repair in the neonatal period, or if they're too small, if they're a preterm baby, then a stent will be inserted in the outflow tract to the right side, and anything to avoid doing a BT shunt, basically. And, you know, I think I'll probably stop there. I think I'm about on time. I could go forward. I've got some other slides, but I'm going to stop there. And thank you very much. Thank you.